Hi, everyone. Hi, everyone. This is Dr. Eric Arzubi. Before we get started, want to get some feedback from you all. Right now, we have, so obviously there's the three of us, part of Project Echo, and then four of you. I guess what we're wondering is in terms of attendance and kind of the attendance kind of falling off towards the last couple of sessions. Is there any feedback you guys have in terms of what could be done differently or better in terms of either the presentation style, the content, maybe getting someone else, which is fine with me, that's okay, or the timing? Any feedback?
It's on the same day as the Project Echo Clinic. Is that in Alaska? Billings. Ah.
Okay.
Good to know.
Got it. So Billings, right? So Billings has a Project Echo. They actually also have a child mental health Project Echo. Right, and then some scheduling conflicts. Is there any? I mean, again, please feel free. I mean, any other feedback in terms of is the format useful, not useful? Is it too long, too short? Anything else you can think of that would you think that others may make others more open to kind of joining? I mean, maybe if there's not, but want to make, yeah.
In addition, other content areas specific around psychiatry, behavioral health, substance use disorder, if there's other topic areas of importance, I think that Frontier, I'm throwing words in Dr. Arzubi's mouth, but I think they're willing and open to hearing a lot of feedback. Yep,
absolutely. So again, if there's nothing now, that's fine. But if please think about it, and we'd love to get the feedback. What I'll do is I will pull up the slides today. We're going to be talking about sort of emotional dysregulation, aggression, agitation in kids. Let me share. Okay. Amber, can you guys see this okay?
Yep.
Okay. So here, I'll go through presentation for you guys. So again, we're looking at the diagnosis and management of explosive children. So as many of you might know, there's a diagnosis that came out through the DSM-5 called Disruptive Mood Dysregulation Disorder, and there's a little bit of a history to this, and I think some of you will know or understand the history and why there was a shift. So there had been, before DSM-5 and the diagnosis of disruptive mood dysregulation disorder, there had been no diagnostic home for explosive outbursts. So there wasn't any one diagnosis that really captured this issue. And there were some downstream effects of some DSM changes in other disorders, like in terms of the criteria for ADHD or ADD at the time, bipolar disorder, and the such. Managed care, which was really forcing people to put down diagnostic and CPT codes. And so people had to kind of felt forced to put down a diagnosis where they weren't really sure what the diagnosis might be. And then again, the FDA over the course of several decades approving atypical antipsychotics and Depakote or Valproex to treat mania in adults and children. So there after DSM-2, there was no diagnostic home because you used to be able to say that emotion regulation symptoms or problems used to be in what was called hyperkinetic child, and then when it became ADHD, they took that out. Conduct disorder was more used to diagnose and predict antisocial personality disorder rather than including aggression or agitation. then after DSM-3, that diagnosis of conduct disorder didn't include impulsive aggression. So again, you're seeing here alone in DSM-2 and DSM-3 some changes that then are kind of restricting where you could put the diagnosis for aggression in kids. ODD, oppositional defiant disorder, often loses temper or often easily annoyed. And these can capture the frequency, but not severity of the outburst. So you don't know if losing temper means kind of just huffing and puffing and kind of leaving the room, or does it mean breaking things? And then intermittent explosive disorder couldn't be used because you weren't sure, because basically it's kind of a diagnosis of last resort or by elimination. So it says that outbursts can't be better accounted for by another mental disorder. So again, there was no great place to kind of pick aggression or agitation as a symptom and fit it somewhere effectively. So think about emotional dysregulation and ADHD. So first of all, what is emotional dysregulation? It's defined as short temper, low frustration tolerance, sudden shifts towards anger, dysphoria, or sadness. So in a study, there were almost 1,200 kids with ADHD, and interestingly, you saw 25% of them had low levels of emotion dysregulation, 50% had mild to moderate, and 25% severe. So again, you're looking at 75% of whom had mild, moderate, and severe. So again, pretty significant. So ADHD, clearly some overlap. It's interesting, there did some studies also and some work on looking at the comparing ADHD, people with ADHD versus kind of community controls with no ADHD. And so in adults even, you saw emotionally overreacting was 68% versus 6%. Quick to anger, 63 versus 7%. Easily frustrated, 86 versus 8%. So that's one piece in talking about ADHD. Next, bipolar disorder. I think over the last couple of years, I think we've started to get away from overdiagnosing, or at least I think people are more aware about the idea that bipolar disorder had been overdiagnosed in communities. But here's a little bit of a background. There had been a conservative or narrow phenotype or sort of description of bipolar disorder, which included sort of episodes of onset and offset of unmodified manic symptoms, which basically are your straight up manic symptoms as defined in the DSM, and understanding that if they're comorbid symptoms with kind of the symptoms of mania, they intensified during that episode. Now, unfortunately, what happened is there was a more liberal and broad phenotype that started to include things that didn't really live in the DSM for bipolar disorder, mania in particular. So emotion dysregulation, people said, gosh, that I'm not sure where else it fits, so maybe that's part of mania. And thinking that might be the definition of juvenile or prepubertal bipolar phenotype. Rages, right? So back in the late 90s, there were some Harvard researchers who really probably took us in a bad direction with the definition of broadening and loosening the definition of bipolar disorder, a manic episode in kids. And then they started toying with the idea of modifying the mania criteria for youth. Thankfully, around 2003, there was the conversation around maybe getting away from describing this within mania and calling it severe mood dysregulation that would live outside of bipolar disorder. But again, keep in mind how difficult, right? So when you think about aggression, there's no aggression on its own can be seen in lots of different disorders, right? I mean, it could be an agitated depression, could be somebody with severe anxieties, people with OCD who maybe aren't able to follow through on the compulsions they have and get really frustrated. So there's folks with psychosis, hearing things or seeing things, or command auditory hallucinations. So again, this was a kind of a real challenge for people. And keep in mind, one of the things we haven't even talked about yet, it's a little bit disappointing that researchers don't address this more often. And that, in my mind, was the experience and exposure to trauma in childhood, right? Because if you're looking at dysregulation, if somebody lives in a dysregulated household, think about the impact that's going to have on growing up, modeling behavior, and the toolbox for self-regulation, right? Because even adults, those of us who might think we have no mental health problems, we still have to have a set of tools that we use to self-regulate. Right. And again, some of us self-regulate by listening to music, by dancing, by running, by exercising. So again, we all have tools for self-regulation. And then the mood dysregulation piece here included a combination of irritability, explosiveness, and hyperarousal. And then there was also the idea that, aggression might simply be a kind of an intersection of severe ADHD with oppositional defiant disorder. So what's been done to clarify things? So there's been an attempt to define sort of a period of time where people are chronically irritable. And during that time, these explosive behaviors might occur. They've tried to say, gosh, there's a difference between adult bipolar and youth bipolar disorder, or the juvenile form, and say basically, gosh, in adults it happens these long kind of sort of periods of up and downs, whereas in kids it's just kind of, it's a faster up and down, right? So the manic episode in youth is probably a lot shorter then. And to date, there's data that says a family history, response to treatment, outcome, and brain circuitry, they differ between bipolar disorder and severe mood dysregulation if you take those two separately, right? So there's other data to show that we can't just say, all right, this is bipolar disorder, because there are things that differentiate sort of bipolar disorder and severe mood dysregulation as entities. And as a result, because of this last point, the DSM-5 committee decided that, mania is one thing, and then chronic irritability is something different. And that's what became the foundation for disruptive mood dysregulation disorder. So again, how do you define mania, right? So it occurs as an episode lasting 1 week, at least 1 week. Behavior that occurs is different than what how the patient normally behaves, and it occurs most of the day, every day during that episode. And then kind of a little mnemonic for the characteristic symptoms of mania, right? So hyperactivity, which is goal-directed and pleasure-oriented, irritability, volatility, psychosis, so grandiosity, hallucinations, or delusions. E for elated, expansive, and energetic. R, racing thoughts, rapid speech. Sleep, doesn't want or need any. So again, even if you just look at irritability, volatility, that's only one, right? And to meet criteria for mania, you have to have several of these. You can't just have one isolated one. And also drugs, right? Intoxication can produce what appear to be manic symptoms. Again, and certainly withdrawal from drugs can do the same thing. And there was, there's also the concern, the idea that antidepressants might trigger or flip the switch on mania. Again, that's not necessarily the case, but if you withdraw the medication and it's given it some time to leave the system, and if manic symptoms persist, then it's possible it's bipolar disorder or mania. And also keeping in mind that it's possible to have mania in addition to other disorders that are comorbid. But the symptoms, you must, and more likely than not, you're going to see those symptoms worsen when a manic episode emerges. So, kind of following up on the idea of a mnemonic, the DMDD criteria, OIV. So outbursts are frequent and pairing in more than one place. I for irritable mood when not having outbursts. So in between those outbursts, the mood is still irritable. V, very chronic, has lasted at least a year. E, explained by another or better understood condition, for example, mania, at least a day, depression, PTSD, anxiety, autism. So again, the E means it cannot be better explained by another one, sorry. So again, that just means that you're ruling out other things first. And then Y for young starts in childhood. The onset is after 6, before age 10, and you're certainly not going to diagnose it after age 18. So again, the idea of irritability, the kind of key components here are irritability and outbursts, right? So there's irritability and then the outburst. So the irritability can occur in between these outbursts. What is irritability and what are outbursts? So how do we define these? And how are these two related? So irritability is defined as a proneness to anger, Has two components. One is, how does this child feel? That can be called tonic irritability. So that person can be easily annoyed, loses temper, easily angered, stays angry, gets angry often. It's almost, how short the trigger is, right? How easy the trigger happens. And then the second is kind of what the child does, phasic irritability. What happens during that time? So in severe cases, it could include property damage and physical aggression. And for many years, this sort of phasic irritability or these angry outbursts were called reactive or impulsive aggression. So again, what you're seeing is kind of the language is changing over time. It's important to keep in mind irritability is kind of a non-specific symptoms, right? So most of the time it refers to the feeling, not necessarily behavior. Because again, irritability describes kind of the fuse. How short is the fuse? It can occur in depression or mania. It can occur in anxiety, post-traumatic stress disorder, ADHD, ODD, schizophrenia, intermittent explosive disorder, borderline personality disorder. So again, these are things that can occur. So irritability can occur in a number of different disorders. And again, I would throw in there OCD as well. And there's certainly conduct disorder and antisocial personality disorder. So how about the link between outbursts and irritability? Annually, 30 million kids present to the emergency room. 3 to 4% of those presentations are for psychiatric behavioral complaints, which include agitation or aggression, and 6 to 8% of those kids are restrained. 11% of 6-year-olds are referred to outpatient departments are for severe tantrums and parent-rated irritability. Around 70% of kids who are hospitalized between the ages of 5 and 12 are referrals for explosive outbursts, not just aggression. Kids in psychiatric and behavioral health clinics represent 90 and 95th percentile of the community sampled irritable children, because again, as you can imagine, irritability and aggressive outbursts are a reason for referral. There's a tool called the IRRI, and it basically kind of collects information around what the child does: hit, kick, spit, bite, or need restraint. And what's interesting about this tool is based on the results from the tool, it was actually able to predict inpatient seclusions or restraints based on the score, the need for inpatient PRN medication for agitation, but it did not predict sort of the construct of often losing temper. A lot of what we know comes from DMDD comes from a study, the Great Smoky Mountain study, community samples. So all in, across ages 9 to 16, about 87% are phasic, sort of tantrums, not sort of overt aggression, and about 51% occur at any one time. 63% are irritable mood plus tantrums, 24% are tantrums only, and 4.1 are irritable mood only. And on average, the tantrum occurred about once a month and lasted about 7 minutes, and about 16% had tantrums in more than one setting. 11.3% endorsed incidents that involved violence. And 90% of the sample had one tantrum about every 2 weeks, which lasted over around 30 minutes. And so what do kids who are clinically explosive, what do? So they in terms of some of the presentations, they argue, whine, sulk. So again, you see that both outpatient and inpatient. Insulting, swearing, shouting, or threatening, pretty big number on both sides. Slamming doors, punching walls, happens on both sides. But what's interesting, the ones that end up in the inpatient unit are the ones that do more of these three things: throwing things, hitting, kicking, biting things, and needing restraints. So that's when it seems to tip over into the need for inpatient care, is when you got throwing things, hitting, kicking, and biting, and the need for restraints. And there where you see those numbers start to really kind of differ. So here, this little map of kind of a differential diagnosis of explosive outbursts. So the most frequent presentation, right? So I'll delete this for a second, right? So frequently you'll see kind of, is there a change from previous behavior itself? Like, so very different than who that person is. In a child, make sure you're ruling out, is there a stressor? Is there a new stressor, something going on at school in terms of learning disabilities or bullying? Something going on at home, like family dynamics or abuse? Is there a history of PTSD or trauma? And teenagers, you want to rule out, make sure you're not seeing anything, you're kind of ruling out depression. Is there a manic episode, an anxiety disorder that we're missing, a PTSD or trauma, drugs, psychosis? And so obviously, as you see, what we're trying to do here is make sure we're, right, because the first instinct might be like, oh gosh, this is mania because it's a change. Well, let's see if there are any other reasons for change. If something that's chronic and they're seeing irritable outbursts in between, seeing irritability between these outbursts, then that's your DMDD diagnosis. If it's chronic and there's no irritability in between, then you might be looking at ADHD plus oppositional defiant disorder. And then you also want to make sure you're not missing autism spectrum disorder, right? Because as we know, there's chronic irritability, or there's significant irritability in kids who've been diagnosed with autism spectrum disorders. And important to recognize that it's rare if it's neither DMDD or bipolar disorder. Oops, let's see. So this just talks about some of the models, some of the kind of internal models for mood dysregulation and reactive aggression. So in some situations, there can be it's kind of this frustration when a reward is being blocked, right? So there can be increased activity and aggression where there's a goal or a kind of prize is being blocked, and so that can lead to the frustration. It's kind of this frustrative non-reward dysregulation. Then there's aberrant threat processing, and that's when a child maybe misperceives the size of the threat, kind of overblows the kind of perception. That could be as a result of chronic history of abuse and neglect and being triggered by what's chronic PTSD. There's a behavioral model where there's a kind of a dynamic between children and adults, caregivers, that kind of reinforce the wrong things, and so parents thinking they're doing the right thing, or maybe rewarding or responding to behaviors in a way that actually triggers and causes more problems than reduces. And then cognitive inflexibility, really not accessing a broader toolbox to solve problems. They see maybe only one usually unhelpful way of solving a problem, and they keep doing it over and over again. So in terms of conclusions, there are evidence-based useful psychological interventions, whether you call it irritability or impulsive aggression. Keep in mind that the tonic and phasic behavior, aspects of irritability are different. The psychological interventions take multiple sessions and committed caregivers, right? So the caregivers need to be involved. It's most effective for tonic irritability, kind of the in-between the outburst piece, right? Because when they're outbursts, obviously the frontal lobe is shut down and it's hard to kind of interact or communicate with someone who's in the middle of kind of this phasic outburst. Hard to know the impact on that piece, and studies don't really do a good job kind of elucidating that. And given that there are many school-based or group-delivered interventions, it's likely that some of the studies that have been done in schools and community groups, the folks are less impaired than explosive kids who are in psychiatric clinics and hospitals. So again, that's just another kind of caveat when thinking about kind of the interventions. And big picture, when we're talking about irritability, aggression, is really thinking about bipolar disorder as kind of certainly a diagnosis of exclusion. It's not common in kids. Again, the more likely things we're going to see is DMDD or ADHD plus ODD. And there might be a background, and not ignoring kind of that might be a background of trauma there, where the ability to develop tools for self-regulation just didn't happen. And then when it comes to kind of interventions, I think we all heard of kind of the stories around kids being over-medicated with antipsychotics like risperidone, Abilify, and others in an effort to kind of quell this aggression. You know, the problem is, I mean, there are good psychological interventions. So, for example, there are, you know, parenting, some really nice parenting classes that can help kids with ODD and aggression. But again, there's always a challenge in accessing those parenting classes, and then the commitment of parents to really partake in those classes. There are evidence-based interventions that might include, you know, cognitive behavioral therapy. But again, you know, one of the problems I think we all face is that there are a lot of great interventions that have been studied, but how easily accessible are they? And gosh, you know, is it easier just to prescribe a medication, which is not a great solution and really shouldn't be the kind of the first thing we reach for. But unfortunately, many communities were limited, and so medications probably get overused because we don't have access to the behavioral interventions. And then one of the other things to kind of consider is certainly considering ADHD as a comorbid diagnosis with ODD, been able to see some improvements there. The other piece is there are, you can certainly consider alpha-2 agonists that are also happen to be ADHD medication, but like clonidine and guanfacine that can be used in aggression. Again, using that before you end up using an antipsychotic. And then the other medication to consider is, especially in situations where you think anxiety might be at the root of this, is you can also consider propranolol. Propranolol kind of goes right at the fight or flight response and can be something to consider in kids with aggression. That's what I have for you guys. Any questions, concerns, or any cases somebody wants to? Here we go. Question. So what are some of the key interventions to help these kids to self-regulate once they become diagnosed with DMDD, especially within the home and the school? So great question. So there's a book, there's an intervention manual called ARC, which stands for Attachment, Regulation, and Competency. So ARC. Even though it's a trauma-focused manual. Let me just see if I can pull it up. Even though it was created for trauma, where is it? Okay, yeah, I'll share my screen real quick. So I'll show you an Amazon, kind of, I just pulled up some on Amazon. So this book here, Treating Traumatic Stress in Children and Adolescents, How to Foster Resilience Through Attachment, Self-Regulation, and Competency. My recommendation, you know, this here, I'll open the kind of the preview here. Some of these chapters are really very useful no matter what. Let me see, here we go. So a lot of these concepts are pretty universal. And so, yes, the first part talks about, you know, the kind of psychoeducation around trauma, part 2 as well. But then the rest of the stuff are universal interventions where it talks about engagement and education, routines and rhythms, caregiver management of affect, attunement, effective response, right? So this first part is, what can the caregiver do differently when interfacing with a child? So again, it talks about how the caregiver can manage their own affect, be more in tune with what the child's experienced, and then providing really effective responses when interacting with the child. The next part here is the regulation part of ARC, right? So it's attachment, regulation, competency. Regulation, helping a child identify, teaching the child to identify what they're feeling. And then once they've identified that, how to modulate those feelings. So again, very, very universal. And then the third part here is competency, you know, creating a relational connection, strengthening executive functions, self-development, identity, right? So this is really building up competencies in the child, boosting self-esteem, boosting the perception that the kids are actually bringing something positive to the world. And so I really like this manual. It's a very concrete, common sense approach with some real interventions. And so that's kind of something I lean on. Other questions or cases. When meds come into play, is there a general timeline to keep them on meds? Can they eventually come off? My answer to that question is related. It's pretty similar to any intervention, any medication intervention we do with kids, and that is, it's all about the risk reward. It's always about the risk reward. Yesterday, I met with a family who has an 11-year-old boy with autism spectrum disorder and pretty severe irritability and aggression. We started with guanfacine. We started with guanfacine to try and help the child regulate. And mind you, they're doing all kinds of other things really, really well. The parents are really working hard. They have the means, so they're able to hire someone to do applied behavior analysis or have an ABA analyst or therapist come in to the home. But the child's really, really struggling and continues to be pretty irritable and gets easily triggered at home and at school. And so, we've started talking about, the two medications that are FDA approved for irritability and autism are risperidone and Abilify. Now, they hate the idea of having to use these mood stabilizers or antipsychotics for autism spectrum disorder. So the conversation I have to have with them is, imagine your child, right? So you have your child now, and you know what your day-to-day is in terms of the strain or stress it causes on the child, but also on the family system, and then the impact on schooling. And then imagine your child, if, let's say, one of these two medications, Abilify or risperidone did work, right? Our goal is that we're going to reduce irritability, reduce aggression, agitation, improve family function, improve school functioning. The downside risk of that is increased appetite, weight gain, and actually, over time, if you do have weight gain and increased appetite, it can increase risk of diabetes. Now there's another medication, again, and it doesn't sound great, right? There's a medication you can actually add to that to lower that risk. It's called metformin. It's used to treat diabetes. But again, as a parent, right, I don't want to be, I as a parent would hate to be in a position to have to choose between these two things, right? Because on one hand, you're looking, do I choose between, having this intervention that might help my child function better at home and at school, but then I have these potential medical side effects, or I avoid those potential medical side effects and I stick with the current plan, which brings in a lot of irritability and agitation and aggression, which makes life difficult at home and at school. Ultimately, it's a very personal decision to see what people are living to live with, right? Same thing with anxiety. Anxiety in adults, same thing. Some people, right? They're like, okay, what do I have? I have anxiety, I overthink things, I struggle, I have a hard time sleeping. But gosh, I don't want to take medication because I worry about these side effects, these 3-4 side effects. Well, I think, again, the first decision is the patient or the family's decision. What's the risk reward? And then when you're thinking about, and Caitlin, you were asking about eventually coming off, same question. If things are going well, and the quality of life is improved, let's say for the family and the child, what's a good argument? And again, keeping in mind the risk of side effects, but you have to balance that equation again. It's like, okay, number one, if I stop the medication, I don't know what's going to happen. Things could get worse and go back to the square one again. Maybe we could stop the medication and things actually end up being okay, which would be, that's ideal, right? That's perfect. And then option 3 is, you know what? Things are going well. It ain't broke right now. Let's not fix it. Let's just leave it as is because things are going well. And that's a very personal decision. I see my role to kind of be a consultant and tell them kind of what pros and cons of each one of those decisions, and then it becomes personal. I've recognized and seen in patients and families when the severity of the aggression is very high, there's a big reluctance to stop medication because they remember how difficult things were. But what I tell you about medication, though, is I hate prescribing medication if there isn't also therapy, counseling, family supports at the same time, because right, the medication alone is, I think by now you know me well enough where medication alone is not going to be doing what we need it to do. And so we need to be teaching the parents some other skills, the child some other skills to help reduce the risk of aggressive outbursts at home. Hope that didn't seem like a long non-answer, but that's, I mean, really, that's the way I think about it. Other questions? Do I ever use amantadine? You know what? I've not used amantadine a lot, but I've seen it used, and I know there's some research to support its use in aggression and agitation. So, no, but I not for any reason other than kind of I've just used other things. But no, I'm aware of amantadine. Let me just pull up. Yep. Let me. Here's a. Let's see. Here's a link. Emily, have you seen it used? Have you used it? Cool. Yeah, like everything else, it works sometimes. Other questions? Great. If there are no more questions, guys, make sure please fill out the evaluation for this. Again, if you have any feedback about what it is I'm doing to scare people away, let me know. Let me see. I treat primarily adults, but find it really helpful to hear these lectures, understand the history of many patients. Yes, totally agree. Totally agree. I find that having gone through my training in child psychiatry and continue to treat kids, because I also treat adults, I feel I have a much better view on what's going on with the adults I see, because I can imagine them as children and what they've been through. And actually, so I think it improves my clinical acumen, but also improves my empathy, because I can only try to imagine what they've been through. So it keeps me more empathic. So yeah, thank you for that. Cool, people. Good to see you all. I will send the slides over to Amber and crew, and you guys have a copy. Take care.